Evening to all. I'm Ashwati Shilai, Brand Manager, Urgoclean AG, and we are very proud to launch Urgoclean AG in India, the only silver dressing with a complete and continuous cleaning action. And we are very pleased to welcome all our experts in wound care specialty, especially in diabetic foot ulcer, venous leg ulcer, and pressure ulcer, to be a part of our product launch. And today we have our amazing speakers to deliver our sessions and also clinical cases. They'll be delivering the sessions. I welcome all our eminent speakers and participants to Urgoclean AG Digital Launch Symposium on behalf of Urgo Medical Family. Now I would like to call our marketing manager, Mr. Pratik Bide, to deliver our corporate concept.
Thank you, Ashwati, and thank you especially to all those who have gathered here on a weekday afternoon. To be very honest, we would have loved to be there in Bangalore, somewhere close in a hotel close to the Bangalore Palace, but unfortunately that is not feasible right now, so we cannot wait until the next time. I would just like to tell you who we are, what is our mission, and what are we aspiring to do in India. So I would quickly take us through our mission in India. First, quickly, if I were to talk about who we are as a company, our corporate identity has evolved over the last few years in India. The roots of the company are here since 1996 in the form of UCare Pharmaceuticals, who were the pioneers of collagen-based skin substitutes, and I'm sure you are used to using some products from UCare like collagen and biofilm. Since 2016, UCare and Urgo, a French multinational company, together entered a joint venture as an Indo-French collaboration to co-promote products in the Indian market. And in 2019, when Urgo took an extra step in India, we became UCare, which is part of Urgo Medical, which became part of Urgo Group as Urgo Medical India. So we are really evolving from a small local organization into a large global organization, and that is something which is a very important part of our mission, to be having a global perspective. So who is Urgo Medical India? Yes, we are a French multinational company. We come out of France. We are in advanced wound care. But what I want to talk about is our mission and our philosophy. As Urgo Medical India, we claim to heal people. And our mission number 1 is healing people suffering from wounds. And mission number 2 is making a difference for the healthcare professional that help to heal patients. And how do we go about achieving this mission? Is through 3 pillars. First, we put patients at the heart of everything. As a philosophy, we don't think of only managing wounds, but we want to treat patients suffering from those wounds. So that is a very critical thing that you will find in all the offerings that we bring to you. The second pillar is caring for caregivers. We have a very strong partnership approach with our healthcare professionals in all the countries. So we don't really think of our customers as customers alone, but as partners in healing patients. And thereby, we have many educational programs and tools that we have worked together with healthcare professionals in different countries to improve the standard of care provided in different pathology areas. The third is we believe in leading with science. We have a very strong investment in R&D, and we bring robust clinical evidence so that you feel confident before using a particular product brought by us on your patients. And this is not just some words on a slide. I would really like to back it up with some action. So when we talk about putting patients at the heart, we have launched recently a diabetic foot ulcer awareness campaign globally, and we are bringing it soon to India, which is Save Feet, Save Lives. And we would really like to partner with those of you in this group who are very involved in diabetic foot ulcer. We know that this is a very important pathology. Every 20 seconds in the world, a limb is lost due to diabetes. And really in India, it's even worse, with 700+ lakh patients suffering from diabetes, most of them at the risk of diabetic foot ulcer. So it is a very important cause for us. And we are in fact working with some of the people in this group on initiatives to be locally done in India. Secondly, I spoke about leading with science, and that is very important for us as well. We really prove the efficacy of our products with highest levels of clinical evidence. We have done more than 80 clinical trials and observation studies, and not only have we completed them, but they have been published in leading scientific journals. For example, one of the studies we will see later today has been published in the Journal of Wound Care, and another study for another product has been published in the Lancet Journal of Diabetes and Endocrinology, which is unprecedented in the world of advanced wound care, as it was usually dedicated only to diabetes. So we are really, really proud of our achievements to be the clinically driven evidence-based company. So over the last many decades, you have already used these products from UCare, Biofil and Collagen. Over the last 2 years, you have also tried and given us very positive feedback about Urgo Tool and Urgo Tool Silver, the first 2 dressings we launched in India in 2018. Coincidentally, this also happened in Bangalore. The first introduction of this concept was in Bangalore when we introduced the TLC technology in India for the first time, which is not surprising as Bangalore is really the hub of technology in India. And we are really very pleased about the positive feedback we have received about the TLC technology and its benefits, which is why we are extending and launching new advanced wound care products in this market. We are bringing new products with TLC at its core, especially a very ambitious pipeline in chronic wound care for the large burden of patients that are suffering from diabetic foot ulcers, venous leg ulcers, and pressure ulcers. Particularly this year, we are launching Urgoclean AG, and we are going to talk more about that today. And as you can see, it is being proven in different levels of the pyramid of evidence, starting from in vitro studies to RCTs to observational studies. We also have a product coming next year in India, and we will be very proud to present Urgo Start for all those involved in diabetic foot ulcer, which is one of the only products in the world, the only wound care dressing in the world suggested by the IWGDF guidelines for diabetic foot ulcer, which is also having a very large body of evidence all across the pyramid of evidence. So we really would like to bring these innovations to you, to bring these products to you for practice and for healing your patients faster. So moving on from knowing a bit about our company, I would like to come to the panel that is going to talk today, Dr. Pavan, Dr. Sanjay Sharma, and Emilio, who is our colleague. To quickly introduce the speakers of today's panel, first I will start with Dr. Pavan. Dr. Pavan is a specialty consultant for ankle and foot surgery at Karnataka Institute of Endocrinology and Research. He's very active in many scientific bodies and associations in India, including Indian Orthopaedic Association, Indian Podiatric Association, and he was past secretary of the RSSDI Karnataka chapter. We are also very privileged to have Dr. Pavan, who gave us the first positive feedback about Urgoclean in India and how to use it and deploy it for infected chronic wounds. So we are really thankful to him to start off this feedback with us. Then I would like to introduce Dr. Sanjay Sharma. Dr. Sanjay Sharma is a master's in surgery and has a fellowship from United States for Podiatric specialty. He is an entrepreneur, a founder of Foot Secure Clinics and Yostra Labs, particularly in diabetic foot ulcers. And apart from that, he's very active in associations as well. He is currently the joint secretary of the National Body of Indian Podiatric Association, as well as a telemedicine expert who has been a regular advisor to the government of Karnataka on telemedicine. I would like to also point out that Dr. Sanjay Sharma was awarded the Rising Star Award by Times Health and in association with government of Karnataka. So we are really privileged to have him today with us speaking about Urgoclean AG. And lastly, I will introduce my colleague, Emilio Galea. Emilio is our International Medical Director at Urgo Medical. He has a MSc in Skin Integrity and he's a wound care clinician with 20 years practice around the world, especially in the Middle East. And Emilio has also initiated a very great Urgo Education and Training Alliance, which partners with SCPs for developing training programs together, which he's leading. So without any further ado, I would like to hand over to Emilio to take the agenda further today. Over to you, Emilio.
Thank you very much, Pratik. I need to share my screen though, Pratik. Thank you. I hope you can see my slides okay. So we will give you an introduction to this. I don't call it a dressing, I call it a wound care modality because the actions it does is quite different from other dressings, which usually have just one objective. This dressing has more, as we will see. When we're looking at the signs of wound infection or wounds at risk of infection, the issue is that all the wounds contain microbial activity. And what we definitely know for sure is that especially the chronic wounds will have the presence of biofilm formation. So what is happening inside these wounds, especially we're talking about the chronic wounds here, is that you have the multiplication of microbes that will at the end of the day become biofilm. And as a result of this, you get the slough and the increased exudate. So basically what we need to do, having an antimicrobial on its own is not enough. Having a modality that cleans the wound is not enough. We need to combine them together to get the best care we have. And we know that biofilms are an issue. Why? Because of this APS. The APS, I call it like an umbrella that shields these microorganisms. we call them microorganisms. We don't just say bacteria, because there's more than bacteria. There's yeast, there's fungi. So that already makes us thinking that if we're going to remove the EPS, we need something which is essentially effective against all these types of microorganisms. Without removing the EPS, we cannot go into the microorganisms and kill them. And I'm sure all of you are very much aware of the cycle of the biofilm. And what is very interesting about the biofilm is how much time it takes for them to form these microcolonies again and forming the mature biofilms. And we know that leaving a dressing in place for a longer time as possible is one of our goals. First of all, probably our patient for a long time will be being cared in the community, so they don't need to come to us every day. Even if they're in the hospital, the increasing amount of payment for the dressing is because of the healthcare time. So we need something to make us rest assured that the EPS is being removed and continues to be removed film because of that EPS. The silver or whatever antimicrobial you're using is not gonna be an issue. So how are we going to treat the biofilm? We need to destroy it by mechanical action. And when we talk about mechanical action, there are different types of mechanical action. We can do manual mechanical action, but the problem is that the EPS will come again very quickly. So we need to find a way how to keep the wound clean. And the way how to keep the wound clean is to find something that we can put on the wound that removes the EPS for us. One of the main issue of wounds and one of the big challenges for us clinicians is exudate. And when we're talking about exudate, many times we think about dressings that wick up the exudate. But wicking up the exudate is not enough. It's like having a leak in the roof. If I just paint over the leak will come again. We have to go to the root cause. And the root cause of the exudate, that's the microbiology of the wound bed, where we have that excess microorganisms, the slough and the wound debris, which is causing that inflammatory process there. So how can Urgoclean help us? The first part of it, and referring back to what Pratik said, that we are big in evidence. So whatever we claim, we have to have proof behind it. So whatever I'm going to tell you, I will prove to you. The antimicrobial, which is not enough. Antibiofilm, together these two will fight the local infection, destroy the biofilm, but more importantly, prevent it from reforming. You might be aware of the TLC-AG healing matrix, which is the previous dressings that you might have been using, the Urgo tool AG. The difference here is that now we have the complete and continuous action because of the polyacrylate fiber. So we have two technologies that are working hand in hand together to make sure that that vicious cycle that we talked about a couple of slides ago is broken. So as I said, you have the TLC-AG healing matrix. The TLC technology, lipotocolloid, has been proven that it is atraumatic for both the wound and the patient when we remove it, but also supports the fibroblast proliferation once the wound starts going into that proliferative phase. It has been proven in vitro on many different types of strains over 7 days, but even as early as 24 hours, and restoring that healing process that we talked about. And this, long story short, just some of the in vitro studies that are done, the different types of strains. It is a broad spectrum, it is fast, and we know it works as an antimicrobial. But as we said, antimicrobial is not enough. We need to go further ahead. And what happens with the polyacrylate fiber? So going inside the dressing, if we may, you have the polyacrylate fiber that works like a magnet. And that magnet over there is not just a marketing stunt. It's the actual truth that happens, because an in vitro study has shown that the fibrin and the dressing provide a positive and a negative reaction, and then you have that kind of electrostatic magnetism that happens there. So what is good is that the slough attaches itself to the dressing, rather than when you remove it, you remove the slough. And that is how it works on the EPS, because when it is removing the slough and cleaning all that wound, then it takes care of the EPS as well. One very important part, which is not shown in this slide, is that every fiber, every polyacrylate fiber, has an acrylic core inside it, which gives it its tensile strength. So it enables you that when you remove it, you are removing it in one piece. And the polyacrylate fibers also allow the vertical absorption in order for the exudate not to spread. So as you see here, whatever we say, it has been published, it has been proven, and this is taken from a randomized controlled trial. It didn't have a huge amount of patients, but it's not the amount of patients, it's showing what and how the dressing does. And I would like to draw your attention to this picture here in the center, where it shows exactly what I was talking about. So the slough which is on the wound is attracted to the dressing, and when it is removed, you basically are throwing away the slough and the biofilm away with that. So we know that there is continuous cleaning action for up to 7 days. The reduction of that sloughy tissue that we were talking about, importantly, leading to the removal of all the local signs and symptoms of infection. But not only, it also helps in the reduction in the wound area, because once the infection starts going, the TLC healing matrix will help with the proliferation of fibroblast. The graph on your right is exactly what I was talking to you about previously. It's not how much the dressing can contain the exudate, it's how much the dressing can treat the cause of the exudate. So over there, you see that the massive reduction in the exudate was achieved not because we were wicking it up, but because we were removing the cause of that exudate formation. And then we start talking again at what we hinted, that destroying and removing of the EPS. So you have that continuous cleaning that will remove the EPS. Once the EPS is removed, then the silver that has been proven in the in vitro study can go in, kills the planktonic bacteria, but also blocks the biofilm from reforming for, again, up to 7 days. And this was an in vitro study that was really quite interesting, because obviously we wanted to show that the dressing is effective against biofilm. And this in vitro study effectively shows you how much of the biofilm is killed. And as you see on the graph here, immediate after 1 day, and as we said, it is sustained up to 7 days. Other studies have been done, and even comparative studies with hydrofibers, and were showing that the superiority and the broad spectrum of the antimicrobial action, but also how powerful the dressing is against the biofilm. And this is the study that I was talking to you about that was published also on the Journal of Wound Care a couple of years ago, where we compared the Urgoclean AG with a dressing which is made out of hydrofiber. It is called AG because it's got silver. The plus, it's because it's basically 2 dressings attached together. And that extra element is what is called ETTA, which is a chemical substance. So basically, this dressing treats the biofilm by means of a chemical action. The difference is that Urgoclean doesn't treat it chemically, it removes it mechanically safely. And at the end of the day, as you see from the graphs, it's basically superior in its activity against some of the most common biofilms that we see, like MRSA and Pseudomonas aeruginosa. In vitro studies are good, RCTs are good, but what about the reality? And if it comes to reality, we can't go too much further than the study that was conducted in Germany by Disman Joachim and a group of his colleagues, where they actually tested the dressing on 2,270 patients. And what is nice about this study is that it was a non-interventional. So nothing was changed about what they were doing to the patients already. The only thing that was changed was the introduction of the Urgoclean AG. So they wanted to show that this Urgoclean AG dressing will help in real life conditions. Another interesting thing is the diversity of wounds. There were quite a lot of diabetic foot ulcers, but there were any type of wounds, anything from surgical wounds to burns, all of them were included. So the patients weren't randomized or the patients weren't allocated. The patients were treated under the normal conditions that they were doing. So again, because of time, long story short, we go to the results where it shows the effectiveness in reducing the number of infected wounds, obviously the local signs of symptoms of local wound infection just after 2 weeks. And when you think about many of the wounds, most of the wounds were chronic wounds, pardon me, especially diabetic foot ulcers, you see huge results within this short period of time. Again, the level of exudate was reduced almost to the exact level of the RCT. And this is the nice thing about observational study. And this is why I love observational studies, is that they take what has been proven in a controlled fashion and put it in the reality of the study. And if you're reading about evidence in the last couple of years, that pyramid that we talk about sometimes is being jumbled up. And we are saying now that observational studies are as important as RCTs because we can't manipulate. It is done as is and showing us what is being done in the normal day-to-day treatment of patients. As I said before, Urgoclean AG, together with the TLC technology, doesn't just clear the wound bed, doesn't just act as an antimicrobial, doesn't just act as an antibiofilm. It helps in starting that healing process. And what is really amazing in the study, what they were showing is the amounts of wounds that they were treated would show a huge improvement in the healing process, which shows almost 91% showed this improvement. But not just that, we are talking about also what is one of the most important things that we needed, removing of that sloughy wounds, removing of the slough, which is really, really tenacious. And sometimes you know that we cannot take it off by surgical or debridement or by using a curette. The dressing helps us remove that tenacious slough that is so difficult to remove. And as Pratik showed you, you already have seen this in the slides in the introduction. There is a huge body of evidence behind it. We believe in Urgo that evidence is important. So we have the RCTs showing the superiority hypothesis of the dressing, the superiority of the results of the antimicrobial, the antibiofilm, and the cleaning action. However, we take it a step forward. We do go and meet clinicians like you're gonna meet today who don't just use the dressing in Europe. This is not just a dressing for Europe. This is a worldwide dressing. So we need to see if it works in other countries. And definitely by my very two esteemed colleagues, which are going to give the presentation after me, you will see that this dressing works on all our patients very effectively and very efficiently. So as in the introduction, we're talking about that this modality is not just a silver dressing. It's the only silver dressing that will help you to continually clean the wound, help you to effectively clean out that wound, remove that slough, which is so tenacious and such a huge problem. But most importantly, in chronic wounds, set our mind at rest that we're gonna get rid of that biofilm once and for all. It will not come back again, because as long as you are using the dressing, the EPS cannot form on the wound bed, and therefore you will not have the issues with these type of problems. Thank you very much. That is all from my side, and I want to leave as much time as possible to see the amazing cases and the amazing presentations from our dear two doctors. Thank you very much. Pratik or Ashwati, are you going to present the next speaker?
Thanks, Emilio. So I believe I've already done an introduction of Dr. Pavan. If he would like to share his screen and take us through the clinical cases he has successfully done with Urgoclean AG, please. Over to you, Dr. Pavan.
Good evening, everyone. Thank you, Emilio. Thank you, Pratik. Good afternoon, good evening, wherever you guys are. Okay, let me just go through. I will not be talking about the theory which Emilio has clearly gone through. I will be showing you the cases that I have used this in, and I'm sure you guys will have some questions. I will be more than happy to take these questions as and when we go forward. So as Emilio said, what is the ideal diabetic foot wound dressing that we are looking at? These are some of the points which come to mind. Should be skin friendly, should not cause maceration, should absorb the exudate, should be antimicrobial and prevent biofilm formation, should not damage the healthy granulation that has already developed, should aid in epithelialization, should decrease the pain during dressings. And can we think of smart dressings? I guess this is for the R&D team of Urgo, where the dressing senses the wound type and acts accordingly. That's some time to go, but yes, I think we will come there. This is what Emilio was talking about, the perspectives in antibiofilm therapy. I'm sure all my esteemed colleagues who have joined me today, they know the importance of the antibiofilm therapy right now, because most of these chronic wounds that present to you, almost 80 to 85% of them will have some amount of biofilms, and just doing regular dressings or debridements will not help you when you are treating them. So there you go, my first case. This is a 48-year-old presenting with an infected right great toe wound after a pinprick, poorly controlled diabetic, but he's an educated patient open to ancillary treatments like hyperbaric oxygen therapy. I guess all of you can make out the erythema. Patient was already having fever, so that's how he presented to me. And we immediately, in the same debridement room, we gave him local and debrided the wound. And yes, because we saw that the patient's septic features were not coming down, we had to take him to a OT, think of an amputation, did the amputation, the first metatarsal head excision, and then we just put stay sutures. You can still see the erythema there on the base of the second, third, and fourth toes. This is what we are worried about usually. We would want to save as much of the flap, the dorsal as well as the plantar flaps as possible. And invariably, they come back on day 1 or day 2 like that. So you see, we already have some amount of flap necrosis on the dorsal aspect. And although the wound assay looks clean, but still the erythema, the residual infection is there, which we can make out by persistently high CRP. And that was how the wound was looking. So we put him on HBOT, and this is after 3 weeks of HBOT. I think all of you guys can make out the first metatarsal, which is exposed, the cut end. And if you can make out here, the second metatarsophalangeal joint, that was also getting exposed. And these are the classic features of a chronic non-healing wound. The peri-wound maceration, as Emilio said, that's because of the biofilm formation. So patient was informed about this new product, and started on Urgoclean AG. So it was a 4 weeks old infected wound with slough and foul smelling discharge. Pain score was around 4 to 6, the visual analog scale, with moderate exudate and peri-wound maceration. The wound was earlier treated with papain-based creams for chemical debridement and cotton absorbent dressings. So how did we start? We just cleaned it with normal saline and we started with dressings with Urgoclean AG. And that is how the wound looked at day 0. You can still make out that peri-wound maceration, the exposed metatarsophalangeal joint, and that is how it looks at day 18. We change the dressings once every 3 days, 3 to 4 days, and after 3 or 4 dressing changes, pain and exudate levels had decreased and the wound bed started appearing healthy. The wound size had gradually reduced, and after 6 dressings change, the wound appeared healthy with granulation tissue. And that is how we follow up the wounds. We have softwares with us which help us in categorizing all these things that you see here in the form of a chart. The size has gradually reduced, the wound bed has improved, slough has reduced considerably, exudate has reduced considerably. The pain score, as you can see, was almost 0 on the last dressing that we were doing. The cleansing agent was only normal saline. So that was the progression of the wound. Conclusion, after 3 to 4 dressing changes, pain and exudate levels had decreased and the wound bed appeared healthy. And by the 6th dressing changes with Urgoclean, the wound side had significantly reduced, and we can almost notice a healthy wound bed with granulation tissue. But as you, these were the secondary procedures that was required for closure of the wound. We had to do filleting, we had to remove the second toe because of the exposed metatarsophalangeal joint. We did a filleting and primary closure along with a small skin graft. I think all of you can make out that the metatarsal head got completely covered after we started using Urgoclean AG by a proper granulation tissue. And this is after 3 weeks. The most important part is we were able to save some amount of the proper sole skin, which will help in weight bearing for the same patient, although he will require customized footwear. And this is after 4 to 5 weeks of skin grafting. The wound had completely healed and the patient has been using customized footwear and wound free for the past 6 months now. Right, this is a very common case which most of you will be getting. A patient who comes with an infected lateral malleus bursitis. This was a 43-year-old patient, 3-month-old. This patient had already undergone lateral malleus bursa excision, but the pain score was not that high in this patient. The wound had moderate exudate with healthy granulation and slough, with unhealthy, sorry. The wound had been initially treated again with papain-based creams. So this is how it progressed from day 0 to day 21. And in this case, we always used only Urgoclean AG. We did not change it midway because it was showing us very good results. And as you can make out, the wound size considerably reduced. This patient, again, sorry, I don't have the final follow-up images, but the wound has healed completely. This is case 3. This was a case of a stabilized Charcot's with a midfoot non-healing ulcer. The biggest problem in this patient was he was a patient with a number of comorbidities, 72-year-old, a 4-month-old infected trophic ulcer with measuring around 10 centimeters square. And pain score was 5, even though patient had neuropathy with moderate exudate with peri-wound maceration. Patient had been initially treated with recombinant epithelial derived growth factors. Patient was appropriately offloaded with a pneumatic cast. So that is day 7. Just with 2 dressings. Dressing was changed every 3rd day. The wound size has gradually decreased, and after 6 dressings, the wound is completely clean. If you can make out these flaps that you can see, the medial and the lateral flaps. This is what we are worried about when we are taking care of the wound, because these form recesses wherein it becomes very difficult to take care of all the bacteria, and chances that bacteria are still there in these recesses, giving rise to biofilm formation again and again. So again, in this patient, we had started using, the wound has considerably reduced in size. The wound is, that is how it looked at day 0. That's how it looks at day 7 and day 21. You can clearly make out the wound has started epithelializing with healthy granulation. There are no more recesses that you can make out because epithelialization has started. And patient is still following up, and he will have a healed wound, I'm sure, with the offloading that he has. Case 4, again, a bad lateral malleus bursa infection, 46-year-old farmer by occupation, history of swelling and a draining sinus, and a case of infected lateral malleus bursitis, underwent excision at the bursa at a different hospital. Peroneal tendons were exposed with a big clean wound with a higher VAS score. Patient always told me that the wound was very painful. So we had to make the patient undergo a peripheral arterial disease assessment also for this. But thankfully, everything was okay. The only problem in this was the exposed peroneal tendons. So this patient was again chosen to see whether Urgoclean AG actually works on such cases wherein the tendons are exposed. And this was on day 0 when he presented to me. After a thorough debridement, we started using Urgoclean AG, and this was in our dressing rooms. This was on day 7. On day 11, patient came from a different city. So patient was given these specimens that we had got, and he started following up with us through the video calls. And we had to train the doctor where he was going to start just cleansing it with normal saline. As you can make out, the granulation has developed over the peroneal tendons. And this is how the patient presents to us after 5 weeks. A completely healed wound. We had, in fact, after 4 weeks, we told the doctor to stop using the Urgoclean, and he was shifted to Urgo tool, a simple dressing. And after 5 weeks, we have complete resolution of this wound. So in conclusions, it gives a very good option for wounds with slough and biofilm, Urgoclean AG. The infection and biofilm are completely cleared, as we can see in most of the cases that we have shown you. There is observed good desloughing property, and wounds are completely cleaned, managed and reduced. You can easily manage the level of exudates with Urgoclean AG. I have personally not used a foam dressing over Urgoclean AG. Probably the reason being that most of my patients had only moderate exudate. But I guess if there is a very high exudative wound, we can also think of foam dressings over it. They definitely improve the healing rate and reduce the wound surface area, controls the peri-wound maceration, and thus helps in preventing secondary bacterial infections. And as I showed you, can be used with other Urgo tool AG, as well as Urgo tool as a complete range for wound healing. Thank you. I'll be more than happy to take questions. Prateek, do you want me to take questions now or at the end of Sanjay's talk?
Yeah, maybe we can have, I believe we have accounted for a special question answer session at the end of Dr. Sanjay's talk. So we can keep the session till then. Of course, should anyone have a question, you can drop it in the chat box and we will take them up first during the question answer session.
Done.
Thank you, Dr. Pavan. We are really happy that you have given us this positive feedback and have this success with the clinical cases that you have performed with Urgoclean AG. I would like to invite Dr. Sanjay Sharma to present his cases to us now. Dr. Sanjay, if you will please share your screen from your side.
Yes. Translate. Okay. Is it visible? Not yet?
Not yet. Yeah, it's coming. It's good. We can go.
Sure. I wanted to present it in a presenter view, but somehow it didn't click. Okay. Probably influenced by Dr. Pavan after he did the first trials of Urgoclean AG, I started using it with few of my patients, and typically for this case study series, we had identified about 4 patients. One patient expired due to COVID in between. We couldn't, I have not included that case study in here, but the rest of the 3 are in here. So I don't know why is this not. So the first case was a diabetic patient, and she had also rheumatoid arthritis, hypertension, and also had a complaint of an abscess on her left foot. So some doctor, a local doctor, had done an incision and drainage and removed the abscess from there, and but the wound was not healing. And this is how she came to me on the day 0. And I had to re-debride the wound. This is exactly the way the wound was there. I had to make a longer incision and remove all the debris and do a debridement, thorough debridement before we, and then started off on the Urgoclean dressings. And so we just applied it. So, removed the Urgoclean from the thing and started applying it continuously. And there was a small amount of exudates that was being there. There was infection that I could see, and the pain score was pretty severe. Interestingly, even though if she was a diabetic patient, there was no neuropathy as such, and she had a very, very high pain score. I would clearly rate it as about 9 out of 10. And so we did a cleansing of the wound with normal saline and dressed with the Urgoclean AG, and started following it up. She lives pretty outside of Bangalore, and she used to come here very infrequently, in a sense. We couldn't do it at every alternate day or every 3rd day, but we started off using the Urgoclean AG on every 3rd day, and gradually, because she wasn't able to travel to the hospital such frequently, we kind of started increasing the frequency of the dressing changes that we could see. And we see a clear healing of the wound, healing of the macerations around it that is there for the day 25 that we could see. So the wound size gradually reduced, even the depth kind of reduced, the infections reduced, and also the peri-wound area was pretty clean. And after about 2 weeks, not 2 weeks, 1.5 weeks to 10 days, we started doing the dressing every week. So this is how it looks on day 25. So if you look at the sizing of how we are capturing, there was mild exudates that was being there, which has become nil. The days 0 or the day 7, we had an unhealthy wound bed, which was improving, and you can see a granulating wound bed on the day 25 that we see here. Even though it was not fully healed, and she comes, now it is completely healed, but on the day 25, that was how the wound was. The pain score, as I said, was like almost like 9, and it kind of kept on reducing. Interestingly, earlier the dressings was, which I had to remove it on the day 1 when she came in, or the day 0 when she came in there, it was excruciatingly painful. But once I started using the Urgoclean, the changing of the dressing, not just the wound pain, but whenever we need to change the dressing, the pain was very minimal, and that is what it was pretty interesting to see. And she was like pretty comfortable. Otherwise, she was like, no, I'm not going to the clinic because it's going to be painful. So this is how we look at it. Day 0, post my incision and drainage, this is how the wound was there. We started dressing with Urgoclean AG. and we see this a little bit of maceration and other things that we see on day 18, and when like in day 25 we see a pretty clear wound. As I said, mentioned, the highlight of this was apart from the infection reduction, it is also about the pain during the dressing changes that was easily manageable. The second case that we are getting into is again a male patient with a history of diabetes, came post-amputated, infected wound of the second and third digits along with tunneling. So there was an wound history. There was a 12 weeks old infected wound with tunneling, bone exposed. Pains, he had neuropathy, so the pain score was mild. He didn't have much of the pain or anything, but he had a callus in the plantar aspect of the wound, which the pictures here do not change. So that is how he was presented. There were several, not several, there was a culture and sensitivity done. He was put on also on IV antibiotics based on the culture and sensitivity, and also started off on the Urgoclean AG. So here, because it was a tunneling wound, what we clearly did was probably, if you could see the video, we took this Urgoclean AG, cut it into spirals like this, and just inserted this Urgoclean AG into the tunneling wound, just like this. So that is what you can see there. So in both the tunneling wounds, we could insert this Urgoclean AG regularly post cleansing of it. And then this is what we see in day 11, where it was granulating, and this is what we see in day 30. I see a little bit of maceration around it, but it is completely healed now. Coming to the third, so this is the statistics that we see of the second case that we did, where it was granulating, or a little bit of maceration that was there, and it was completely granulated wound that we see. In the, sorry, this is going back. So you can see the progression and also the application of Urgoclean AG. After 7 dressings, changes of Urgoclean AG, exudate levels had subsided. The wound is closing with some kind of a maceration that we see there. In case 3 that we see, there were multiple, ulcers that we can see in all the digits except for the hallux. There was ulcers in all the digits in either side of the fingers, and there was also exposed bones and the tendons that we can see. It was a 2 weeks old wound. They were doing standard dressings with a local clinic, and we started with him on the Urgoclean AG after the cleansing and debridement. So again, we cut the Urgoclean AG to the length of the digits, and then wrapped it around so that we cover both the sides of the digits, both medially and laterally. So that is how we started putting it on him. So there was day 0 and day 8. We see a lot of granulation tissue that we can see, and in terms of day 38, we see it's completely healed wound. So there is a little bit of skin, the knot, so little bit of skin that is seen here, but otherwise most of the wounds are completely healed by about day 38. So this is a brief summary of the third subject that we had, third case that we had, where there were multiple wounds. There was a bone exposed in the third digit, and there was soft tissue exposed in the tendons exposed. So I have mentioned it 2 centimeter, 1 centimeter. This would be wrong, because there were multiple ulcers that we were treating, and multiple digits. So we just took the largest ulcer that was there and started documenting it. So and like in terms of the exudates also, there we could see pus in the early days led to serosanguinous exudates, and then there was no exudates at all at the end of it. So, and it was completely, we were using the Urgoclean AG itself. You can just see the way it went through. So you can see on day 23, I think this picture was not there in the before one. And this is what we see in day 38, which is completely healed wounds. So conclusion or the summarizing it. So I could see from my experience, we could control the infection, completely avoid the biofilm formation. We could also, do the dressings in a longer intervals. Like, as I said, the first patient after some time started coming only once in a week, and the second patient who was coming like once in 3 days, once in 4 days, and the third one was also again once in 3 to 4 days. So the interval of dressing is big, it was longer, so we need not call the patient pretty regularly there. So desloughing properties was also highly appreciated. I didn't see any sloughing around at all once I started using the Urgoclean AG across all these three patients. There was exudates were pretty well managed. I know that this was not none of them were highly exudating wounds, but I also didn't use any of the secondary dressings like foam or anything over it. But for the moderate to scant exudates, I think Urgoclean AG managed it pretty well with just padded a sterile pad over the Urgoclean dressing that I had kept it. For sure, there is an improved healing rate and also a pretty healthy healing. So we don't have to worry about whether we need to debride it serially every time that they come in or not. So especially the first patient where she was absolutely, not allowing me to touch the wound at all. A little bit of cleansing and application of the Urgoclean AG, and also while removing it, the pain-free removal, this helped a lot in terms of the patient compliance and also the healing of the wound. I would say, looking at the standard of treatment that is available, this is pretty much helpful for the patients and also for the doctors per se. Thank you very much.